And I think it's probably fair to say that the coverage of the uninsured probably has relatively little impact on the markets and the situation that would face new technology. The uninsured were not heavy demanders of new technology, and most of the benefit from coverage of them is to provide them with access to existing care so that it can not only improve their health, but also improve the state of the rest of us, rest of our consciences, and probably relatively little impact on technology. The one thing in the dark of night that I sometimes worry about, though, is what if the uninsured were and their inability in many cases, or in some cases as well unwillingness, to pay for medical care because they don't have insurance? What if that was the only thing keeping the technology balloon from floating up to the ionosphere? What if it was the only constraint? I don't think I really believe that, but it still may be worrisome, or at least worth worrying about. Right now, in the U.S., the fraction of healthcare spending paid out of pocket is about 11%. That's actually quite low by comparison with our peer countries that Alan talked about. Just for the sake of comparison, in Switzerland, it's above 20%. Of course, they wear those red and white check shirts and hike up and down mountains, and so they're obviously better prepared to pay out of pocket than we are. But still, and the impact of coverage and the expansion of coverage probably will be to knock another couple of percent off of that. And at least in sort of the general theory of economics, the lower the fraction that people pay out of pocket for expensive things, the less disincentive there is to use those expensive things. So you could worry about it, although compared to a lot of other things that I'm going to talk about in a minute, I'm not going to lay awake nights worrying about it, but still worth thinking about a little bit. The insurance regulation part, for the most part, I might as well give my pitch here. The book argues that the conversion of insurance markets into products that are going to be community rated without pre-existing condition exclusions is the worst possible way to do a good thing. There is a good thing to be done here. You don't want people who have the misfortune of becoming high risks to fail to have access to insurance, or for that matter, to pay extraordinarily large amounts if they're going to get it. Either they get it or they don't. So you do want to think of some ways of cushioning the impact of the onset of chronic disease and things that cause people to be high risks, but doing it by requiring insurers to charge the same premium to high risks and low risks, at least in the economics I learned, is a really bad way to do it, because it's like subsidizing the high risks, which is a good thing, by levying an excise tax on health insurance bought by the low risks, which is a bad thing, because either it will discourage, or maybe both, it'll discourage the low risks from buying insurance, it'll discourage insurers from treating high risks well. They'll engage in cream skimming, and there are better ways like high risk pools or guaranteed renewability. That's a talk for another day. Another, though, potential adverse consequence, and I think at least I talk about in the book, having seen some of this already emerge in Massachusetts, is that once you do set up insurance that's community rated, then you need to worry that there will be adverse selection. You've sort of set up the best possible case for adverse selection. In order to prevent adverse selection, then, you have to have, in many cases, pretty heavy-handed regulation of what insurance packages are allowed to be offered, because almost any innovative insurance package is going to appeal to some risks more than others. Many of them will appeal more to low risks than others. It'll undo your attempt to average premiums across the population if there's a certain policy that can be more attractive to the low risks, and so you have to prevent prevent that. And so what's the application to technology? Well, many technologies, I imagine, are ones that are highly beneficial to high risks, but are at best moderately beneficial to low risks. In the ideal world that I have in mind, there'd be an insurance policy that would be purchased by high risks that would have generous coverage and probably few limitations on access to that technology for people who are high risks, but low risks would either not have coverage or would have much greater, more restricted coverage, higher cost sharing, and so forth. The trouble with community rating is you can't have those two things coexisting. You have to make the coverage uniform across risk levels, and so you may open the door to overuse of the new technology by the low risks who may get relatively little benefit from it. I mean, in principle, of course, if you had sufficient rules about access to care based on illness severity that you could enforce, you could avoid that problem, but that's probably not the kind of level of perfection that we should expect to see accomplished. The third thing that I wanted to, where I do think obviously technology matters is in the issue of cost containment, and I'm really conflicted here.